Hi, my name is Tyler Owens. I'm a student physical therapist assistant at Jeff State, and this is my presentation on a manual technique for pelvic upslip and SI correction. An upslip is when the innominate or the hip bone becomes stuck in an elevated position in relationship to the sacrum, resulting in excessive stiffness in the low back or the hip area. In simpler terms, the ilium has shifted upwards on the sacrum. This causes misalignment at the SI joint and can present as SI pain. And it can also coexist with a rotational malalignment such as an anterior or posterior rotation, which those happen more in a front to back motion, or an outflare or inflare of the hip. An upslip can occur for several different reasons. Traumatic upward forces such as stairs, stepping off a curb, or falling or landing hard on one side of the body. An injury to a muscle or muscle groups that pull upward on the innominate or hip bone, or an imbalance of tension in one side of the hip girdle muscles versus the other. 90% of upslips occur from some form of impact. Stairs are the most common traumatic cause, and quadratus lumborum spasm is the most common non-traumatic cause. An upslip can affect all age ranges, with the more active have a greater chance of getting an upslip versus the less active. They're more common to those in people who are involved in sports, running, lifting, or in high impact activities. And it occurs considerably less often than rotational malalignments such as anterior or posterior rotations. An upslip will present as the iliac crest and ASIS will be elevated on one side. Leg length will be shorter on the side with the upslip. And as you can tell by the pictures here, this person has an upslip on his anatomical left. This is a different presentation than an anterior pelvic rotation, which would have a shorter leg length and a lower or forward rotated ASIS. This can lead to a mechanical dysfunction, not a structural dysfunction, that can cause pain and other issues in the lower extremity. And it can be confirmed with imaging. However, you don't need a doctor's visit or a diagnosis for a pelvic upslip. Manual techniques can be used to correct a pelvic upslip and be applied by PTs or PTAs. This video is going to show how to assess and correct a pelvic upslip. So our reference points are going to be both medial malleoli and the iliac crest and ASIS. So right now I'm checking the medial malleoli to give me sort of a reference point to know when I go up to the hip what to look for. So I noticed that he's got a shorter leg length on the left side, so I go check the hips. He also has an elevated left hip. So he presents with a left pelvic upslip. I asked him, does he have any previous surgeries or injuries on the left side? Because if he did, I may, instead of doing unilateral traction, I may come from the top pushing down. So what I'm doing right now is a gentle unilateral traction. And what I'm feeling is I'm waiting for the muscles and the ligaments and everything to relax. And I'm going to perform a grade 3/4 joint mobilization on the hip once I feel him relax. So I'm just kind of waiting, keep tension right here. You're going to see just a little pull. I did 2 right here, and now I'm going to check my work. So checking there at the malleoli, and also going back and checking at the hips. So I'm going to tell him to bring both of his knees up and perform a bridge. And I'm going to ask, does he have any pain or pressure on either side? And that'll let me know if I need to perform an SI correction. He says he doesn't have any pain or pressure, so we can move on to the muscle energy technique, or the MET. So right now, I've got knees together and I want him to push out for 3 seconds. So it's going to be an isometric. I'm telling him to push, 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 and then relax. And then we're going to go a little further out. Same thing. Push, 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 and relax. And then the last one is going to be isometric adduction. So squeeze, 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 and then relax. He may feel a little pop in his pubic symphysis just because it's going to be mobilized due to the muscles contracting. And then this last one, I told him to bridge again to see if the pain had gone away, which he didn't have any pain before. So that's a good thing. No pain after. I go back and check my work, and he is in line. So pelvic upslip is corrected, and the muscle energy technique has been utilized to mobilize the pubic symphysis and we are good to go. The SI correction technique can be used when they have pain or pressure on either side when asked to perform a bridge. So what I'm doing right now is putting my first and second MCP joints under his SI and then mobilizing the SI using a lower trunk rotation toward me. I'll perform it 3, maybe 4 times, and I'll ask him to bridge again to see if that pain or pressure is gone. If the pain or pressure is gone, that means the SI has been corrected and you can move onwards. If they still have pain or pressure, you can perform it again. Just let them know that it may not be the most comfortable thing. I typically will perform the SI correction before the MET, or the muscle energy technique, just because I like the muscle energy technique to be last to kind of seal in the correction. When documenting a pelvic upslip, if you have a objective finding spot in your documentation, you can just put it as a left pelvic upslip or right, whichever one it was. If there's a spot for manual, you can be a little more descriptive. You can put that you use left unilateral traction with an MET to mobilize pubic symphysis. And in the assessment section, you can put that they had decreased lumbar pain following unilateral traction and SI correction. You can help prevent a pelvic upslip by stretching muscle groups that have an upward pull in the hip. These muscles are the quadratus lumborum, latissimus dorsi, psoas major and minor, and the external and internal obliques. The main muscle groups that oppose the QL and can help prevent an upslip are the glutes and the transverse abdominis. Strengthening these muscle groups can help balance out the pull from the QL by supporting the area and keeping the hip and bony structures in place. So this concept is really interesting to me. This is something that we did a lot in my first rotation, and then I performed a lot in my second outpatient rotation as well. My wife actually has a pelvic upslip that needs correcting quite often. She does have quadratus lumborum spasm and weak hip abductors. So she gets to be my lab partner and my guinea pig. So I fix her a lot, probably a couple times a week, but it does give me good hands-on practice. This is not the only upslip correction technique that you can use. There's a couple other ones, but I found this one very effective, and I like to be hands-on. Hands-on skilled intervention is what I like doing, and it's very interesting to me. So thanks for watching.